We move now to the next speaker, Dr. Fatmah Al-Zahmi. She is an associate professor at the College of Medicine at Mohammed bin Rashid University of Medicine and Health Sciences in Dubai, UAE. She will talk to us about the expanding role of complement inhibition in neurological disorders. She is the department head and consultant of neurology medicine at Parkview Hospital. Dr. Fatmah, welcome.
Thank you. Good afternoon, everyone, and I thank the organizers for giving me this opportunity to speak to you all about this exciting topic, and I hope that I spark your interest in this topic and this new therapeutic target that is the complement pathway as a new way of immune modulation. So it's going to be switching gears a little bit because this is not genetics, this is not pediatric diseases, but I think it's still interesting and I think we're learning more and more. And I think I should use, Okay, so we're going to talk about the expanding role of complement inhibition in neurological disorders. They are being used in other conditions, but my focus is neurological disorders. I have no disclosures. So we're going to start by reminding you about what we learned in medical school not very long time ago, about the what is the complement pathway and the importance of the complement pathway in the normal inflammation and how can it contribute to tissue injury and inflammation and causing disease, and what are the current complement inhibitors that are being used in diseases with emphasis on myasthenia gravis and NMOSD, neuromyelitis optica disorder. So this is so the complement system has been implicated in as causing disease in multiple organ systems, really, from the central peripheral nervous systems to the kidneys to the hematological systems. So pretty much everywhere in the body, the complements have been accused of participating somehow in disease causing. The diseases that are highlighted in red, you're doing the right thing, but basically the ones in red are the ones that there are actually ongoing clinical trials or effective therapy. So in the neurological disorders, as I said, myasthenia gravis and NMO. In the eyes, age-related macular degeneration and hematological disorders with paroxysmal nocturnal hemoglobinuria, HUS, and some types of glomerulonephritis. Okay, so the complement system is a major component of the innate immune system. So if we go back to medical school, you remember that our immune system, we have the innate immune system and the acquired immune system. The innate immune system is the first line of defense, so it's non-specific, and it is the immediate reaction of your immune system. It comprises of the complement system, the natural killers, the granulocytes. So it's non-specific, it starts immediate, and then you have the acquired immune system, which has a memory, and this mediated by T cells, B cells, and the specific antibodies. So the complement system acts as a bridge between the immediate response, the immediate inflammatory response, and then the formation of the memory or acquired immune system. Also important in regulating cell deaths and getting rid of the apoptotic cells. There are more than 50 proteins that have been identified to be important in this cascade, mostly produced by the liver. So you can activate the complement system by 3 different pathways. So the classic, the lectin, and the alternative pathway. What is important, if I can use this. Okay. What is important is that all of them converge into the, if you see C3, so all of them end up in activating complement 3 and then complement 5. And after the activation of complement 5, this will be cleaved into 5A, 5B, and that will create the membrane attack complex, which is the one that leads to cell lysis. So basically, it attaches to the cell membrane, pretty much as drilling a hole in the cell membrane, and then that leads to cell lysis by osmosis. So again, the same picture you'll see many times, but I'm showing you the complement 5, and why do we care about complement 5 so much, which is kind of the major step into creating the membrane attack complex. Now, the alternative pathway has the ability to activate itself. So if there is no regulation to the complement pathway, it can go into a chronic state of activation and inflammation. And that's why we have important regulatory proteins. So they are like the brakes on the system. Without, or if we have abnormal or mutated proteins, this would result in a chronic state of inflammation. And for example, in the disease like paroxysmal nocturnal hemoglobinuria, there is either CD55 or CD59 that are mutated or dysfunctional, which will lead to the complement system to being chronically active, which will lead to chronic inflammation, hemolysis, consumption of the platelets, all the manifestations. So, is this a new knowledge? No, the complement system has been known to be involved in certain diseases since at least in paroxysmal nocturnal hemoglobinuria, there have been demonstration of the involvement as far back as 1966. So it's not really new knowledge. Also in other autoimmune conditions such as rheumatoid arthritis and SLE. However, it wasn't until 2007, so there was some interest in the 90s, started these clinical trials in PNH, paroxysmal nocturnal hemoglobinuria, and eventually this led to the development of eculizumab, which is the first in its class complement 5 inhibitor. And this was a scientific breakthrough, and through translational research where we have the hypothesis that this complement is the main driver of the disease, let's inhibit the activation, and yes, it was very effective in treating patients with PNH. Now, this also sparked interest in what about other diseases that we know complement is involved. So after the 2007 FDA approval of PNH, actually it was started by the pharmaceuticals that was, why don't we try and see if this is going to be effective in diseases like myasthenia gravis? And they did start that, and it was, myasthenia is considered a rare disease, so slow recruitment. It took 10 years to get the positive results. So, what about neurological disorders? So as I mentioned, there is the in the peripheral nervous system, or neuromuscular junction, in the peripheral nerves such as acute or chronic inflammatory neuropathies, and in the central nervous system as well. So, in myasthenia gravis, we know that most patients with myasthenia, 80 to 85%, have the acetylcholine receptor antibody. And so we know since early 80s that wherever there is acetylcholine receptor staining or deposition, there is also co-localization of components of the complement pathway. So C3, C9, C1q, and IgG. So the acetylcholine positive myasthenia and complements, it seems to be playing a major role in the pathogenesis. So that is the myasthenia gravis. I'll talk about the therapy later on, but what about other peripheral neuromuscular conditions? So Lambert-Eaton, which is a presynaptic, so there is evidence such as complement 3 is present or deposited in the presynaptic nerve terminals. And dermatomyositis, there is ongoing trials testing different complement inhibition as well as in necrotizing autoimmune myositis. How about in to move from the neuromuscular muscle, the neuromuscular junction and the muscle to the peripheral nerves? So we have acute and chronic inflammatory neuropathies, acute being GBS, and yes, there is enough basic science to show that there is deposition of the complements in the chronic inflammatory peripheral neuropathy. There is also a correlation between the levels of the complements in the serum and CSF and the disease severity. It's very interesting, as well as in cases of sensory neuropathies and neuropathic pain. Again, these are so some of them there is already studies in the pipeline to see if there are therapeutic targets, while the others are more of knowledge, have not started the clinical research yet. In the central nervous system, so when we talk inflammatory conditions of the central nervous system, most commonly multiple sclerosis. Multiple sclerosis used to be thought T-cell mediated disease, but there's mounting evidence that it's not just T-cell mediated, that the innate immune system, the complements, and the B cells are also involved in the pathogenesis. And this is not a new knowledge, as I said, it's at least 2 to 3 decades. Now, in the NMOSD, there was clear deposition of complements in the, it seems that the inflammation happens in certain areas where there is this aquaporine channels, and the co-localization, co-deposition of the complements, which led to the clinical trials, and now that we have a complement inhibition approved in treating this condition. Also, in the central nervous system, not just inflammatory conditions, but neurodegenerative conditions. There are basic science research suggesting involvement in Alzheimer's disease, traumatic brain injury, ALS, Huntington, and even neuropsychiatric conditions such as schizophrenia. With a specific interest in ALS, because you think ALS is a more of a neurodegenerative condition, but there is also evidence of inflammation, and it is currently a kind of hot topic or a hot area of research using the complement inhibition. So, what are the complement targeted therapies? So if you see this, from the earlier images, this is the complement cascades. All the boxes in yellow are medications or medications that are in the pipeline, either in preclinical phase, or some of them are actually in the clinical phase, and some of them are FDA approved for certain conditions. So these are all therapeutic targets that are being studied, lots of them. The first one that came into play is the Soliris, or the eculizumab, which is complement 5 inhibitor. It is intravenous infusion every 2 weeks. It was first used for paroxysmal nocturnal hemoglobinuria, and then it was studied in myasthenia gravis, and with the famous REGAIN trial, which was very exciting in the adult neurology world, because up until 2017, we had no FDA-approved medications for myasthenia. We know that taking this medication and acetylcholine-positive generalized myasthenia gravis does reduce the disease manifestation, improve the functional outcome, and the response is within a few weeks, and it is sustained. It does require infusion every 2 weeks, though. The manufacturer have then also developed a long-acting complement 5 inhibitor, which is the ravulizumab, and ravulizumab have also been studied in myasthenia gravis. So ravulizumab is IV infusion every 8 weeks instead of every 2 weeks, and it is also as effective in treating patients with myasthenia gravis, with significant reduction or significant improvement in functional outcome. And this was led to the FDA approval of ravulizumab in 2022. So for complement inhibition for myasthenia, again, it's like a lot of explosion of trials and molecules in treating myasthenia, but we have the 2 FDA approved medications. Pretty much one is the long-acting mirror of the other one, so we use the ravulizumab. Ongoing, the zilucoplan is a sub-Q daily injection. So sub-Q, patient does not have to come to the hospital. It's beneficial. The trial is completed and they're awaiting for FDA approval. Ongoing for 2 agents to be given simultaneously, another C5 inhibitor with phase 3 ongoing, and a new target complement factor D inhibitor is oral. That's unique about it, and it is an ongoing trial for now. In NMOSD, we have the eculizumab in the PREVENT trial, and it is effective and it's FDA approved as of 2019 in reducing the disease manifestation and disease relapses and the need for rescue treatment. It is currently they are replicating the study on NMOSD with the use of the longer acting complement 5, that is ravulizumab, and we are hoping to see the same results, so it will be easier to administer every 8 weeks instead of every 2 weeks. It is the complement, the same one ravulizumab is being studied for dermatomyositis, and the sub-Q complement 5 is being studied in necrotizing myopathy, but that was negative and the study was stopped. In peripheral nerve inflammatory conditions, again, eculizumab is being studied or completed phase 3 in GBS, and we're waiting for the results. There is a new target, complement 1Q, is being studied as well. And for multifocal motor neuropathy is ongoing. Again, it's very exciting because as of few years ago, all we had is steroids, IVIG, and when it's really bad, plasma exchange. So having options to choose from is, to me, is very exciting. The other one is ALS, which is a neurodegenerative condition, and it's really pretty much a death sentence when you give that news to the patient. So having interest in ongoing clinical interventional trials to slow down the disease or prevent progression is comes with some optimism. So ravulizumab again is being studied in champion ALS, but yes, it was futile. There is a complement 2 inhibition ongoing and the C1Q ongoing. So we're looking forward to some effective treatment in ALS. So basically that was my talk. It was not meant to be in any kind of giving you any guidelines in terms of one disease, but it's mainly to introduce this new, and I feel even among the neurologists, we still need more knowledge and more education in regards to this new therapeutic target, which seems to have a more effective in reducing the disease severity or disease manifestation. It does come at a cost. The C5 inhibition can increases the risk of meningococcal meningitis, so these patients have to be vaccinated 4 weeks prior, or 2 to 4 weeks prior to receiving the medication, and keep an eye on further treatment options to be available, basically. And yes, so started with IV medications, frequently administered. Second generation is becoming less frequent. Then we're getting into a sub-Q, and then we're getting to the oral, so ease of administration and safety are our new targets. Thank you. Questions?
Thank you, Dr. Fatmah. Any questions?
That was a really lovely talk. Thank you very much. I have a question. Have you any experience using complement inhibition in autoimmune encephalitis, especially in pediatrics?
Autoimmune encephalitis.
Autoimmune encephalitis. So I'm not a pediatric doctor, but autoimmune encephalitis is seen in pediatrics and in adults. I am not aware of any ongoing trials.
Okay.
However, I think it is something to be explored as well.
Right.
There is the complements have been approved, FDA approved in adults, not yet in children. Mm-hmm. Actually, I think eculizumab is being studied in pediatric myasthenia currently. But yes, pediatrics always, once you have the safety, then you move on to applying these to pediatric patients.
Okay, great. Thank you.
Any other questions or comments? Thank you very much. I would like to thank you, Dr. Fatmah, for coming on a Saturday to give this talk on a rare disease and rare treatments. Thank you very much.
Thank you. Good.